All right. So good evening, everybody.
Hello.
Hi, my name is Ben OKANGA. I'm a neurosurgeon from Mombasa in Kenya, country in East Africa. And today's topic will be about advancing neurosurgical care in sub-Saharan Africa. Please allow me to share my slides.
You should be able to share them directly. I had planned it like that. Ah, perfect.
Okay. Okay, you can see them. 1 second. Okay, so this is today's topic. This is advancing neurosurgical care in sub-Saharan Africa. So, as I said, my name is Dr. Ben Okanga. I'm a neurosurgeon working at a public hospital known as Coast General Teaching and Referral Hospital in the county of Mombasa in Kenya. So I'll start with a few definitions. First is regarding regarding income, according to the World Bank. So, according to the World Bank, a low-income economy means a gross national income per capita of $1,145 or less. This is in 2003, using the World Bank Atlas method. And the different economies across the world are ranked according to the per capita, the gross national income per capita. So that you have a low-income economy having $1,145 or less, and you have a higher income economies of with incomes of above $14,005, and between you have a lower middle income economy and the upper middle income economy. As it happens, most of the countries in Africa, especially in sub-Saharan Africa, tend to fall within the low income economy bracket. Other definitions are given about what low economies are based on socioeconomic status, access to water, access to healthcare, etc. And still, most countries are defined as low income by this criteria. As far as neurosurgery goes in the world, I think as of last year, according to some surveys, there are 73,000 neurosurgeons estimated globally, which gives a worldwide ratio of 0.03 per 100,000. Now, sub-Saharan Africa represents almost 20% of the world's land mass, and also contains about 14% of the world's population, but only contributes to 1% of the world's gross domestic product. So the population in Africa is 1.3 billion, and of all this population, there are 1,974 neurosurgeons in Africa. This is the entire continent. Now, another fact is most of these neurosurgeons, about 2/3 of them, they are above the Sahara in North Africa or in South Africa.
I'm sorry to interrupt, but we don't see your slides. I don't know if you're showing slides right now, but we saw them for a moment, but then they disappeared.
Disappeared. Okay, let me try and show them again. Excuse me. Let me share again. Okay. Can you see them now? Are
Ah,
they
yes,
visible?
perfect.
Okay. So um, so I was saying that about 2/3 of the 1,974 neurosurgeons in Africa, 2/3 are in North Africa or South Africa, which leaves just about very few out of 1,974. Only about 700 are located between south of the Sahara to south of the Limpopo River, which is the majority of the landmass of Africa. And even with these few neurosurgeons, there's still quite a big burden of neurosurgery. Just about 15% of the neurosurgery disease burden in the world is in sub-Saharan Africa. So we have a situation where we have very few surgeons with a large disease burden in low-income countries. In Kenya, where I come from, this is the situation. We have a population of just above 54 million, according to the 2022 census. So by now, maybe we're about 56 or 57 million. And the country is divided into administrative divisions known as counties. And the entire country has 45 trained and qualified neurosurgeons. Only 45 for a population of 54 million people. And some of these are, almost retired, not quite active. So I'd say about 40 are active. Majority of these surgeons are located in the capital city here in Nairobi. I don't know if you can see the arrow. It's a little city here. And in Eldoret. And about 2/3 of them. And the reason is that this is where a lot of the economic activity takes place in this country, about 70%, and where you have major referral hospitals and centers that can take care of that at least can provide good infrastructure and good salaries and comfortable life for these surgeons. In the rest of Kenya, which is rural, it's very difficult to find neurosurgeons, so it's underserved. Where I work is Mombasa. Mombasa is if you look at the arrow, it's probably the smallest county here along the coast of Kenya. And next to me, we have this county of Kilifi, where we have 2 neurosurgeons, and we cover this region with this 6 counties and probably a catchment area of 8 million people. So you can see that the situation is quite dire in terms of neurosurgeon to patient ratio. Across Africa, there are several challenges facing neurosurgery. I think beyond the few numbers of neurosurgeons that there are few numbers also of allied specialities. So we cannot work alone. We need anesthetists, we need nurses, specialized nurses, we need radiologists, we need pathologists, we need oncologists, we need biomedical technicians. There are few. There are few. Another thing is that the hospitals need infrastructure and resources that can adapt to the growth of surgery and surgical technology. And again, in Africa, these hospitals are few, and they are very, very few, especially in the rural areas. In some of the bigger economies in the urban areas, you'll find a few hospitals that can support modern neurosurgery to some extent. The training programs in Africa for the population of 1.3 billion, with such a large land mass and such a large disease burden for neurosurgery, there are few. Across Africa, as of last year, there are 106 training programs only, and majority are in, again, Northern Africa and Southern Africa. So in Sub-Saharan Africa, I don't know, probably less than 40 training programs. Again, another problem we have in Africa is poor referral systems. Poor patients will present to a rural hospital. It takes a long time to make a diagnosis. There is no organized ambulance system or referral system. So often the patients will present late. Sometimes it is too late to do anything. So you might find someone having a malignant tumor that is too large to operate on, or that has metastasized already. Another problem we have is resources for diagnosis are limited. You might find that we don't have, there's especially in the rural hospitals, there's a scarcity of, for example, CT scan machines and MRI machines. There's a scarcity of good labs and maybe diagnostics. So this is a challenge for us here in Sub-Saharan Africa. And even though there are challenges, I mean, there have been some strategies over the years to try and counter these challenges. To do with numbers of neurosurgeons, especially training and education it has taken a key role. In Kenya, at the moment, there are 40 residents training in neurosurgery, which is good. We expect in the next maybe 5 years, the numbers of neurosurgeons who are practicing will have doubled. So I think that's very good effort. What we have in Kenya is there are two full-time models of training. One is in the oldest university, the University of Nairobi, where they take, I think, 8 residents per year and train. And then we have a regional program within Eastern and Southern Africa that runs from Arusha. It's a collegiate model. And the idea is to train surgeons in a facility where they can be trained. So if you have a hospital that has a good bed capacity, adequate patient numbers, at least a MRI scan, CT scan, a decent laboratory, good OT, maybe ICU facilities, then you can train residents within these institutions and have them rotate within the country or within the region to get exposure to different facets of neurosurgery. Another strong effort is that surgeons who are trained here are encouraged to stay here. Before, there was a lot of people training and living and going to work outside of the country, but now it is not law, but people are really encouraged to train here, and the authorities try to give some kind of motivation for the doctors to stay within and work in remote areas. Although we still lose a lot of doctors to the urban areas that are more attractive with a better quality of life. The local societies have become more and more organized over the years within Kenya, for example, within Africa, and we have a lot of organized workshops and conferences that are very deliberate in training and strategic planning. A challenge we have, although it's getting better, is access to fellowships to higher surgical training, higher neurosurgical training outside the country, because such fellowships, they're rare within Africa. I mean, in North Africa and South Africa, there are some fellowship programs, but a lot of us have to go outside of the country to get further surgical training, for example, in spine surgery or pediatric neurosurgery. So this is it's not always easy to get. Regarding infrastructure for neurosurgery, and this means apart from numbers, means also equipment ranging from operating tables, there are good anesthetic machines, operating microscopes, drills, and so on. All the machines that make all the technology that makes it easier and safer to perform neurosurgery. This is not easy to get in Africa. A lot of us work in situations where we may not have access to a good operating microscope. Majority of hospitals, majority of rural hospitals, or even hospitals that are considered well equipped, for example, have no neuronavigation or may have a outdated MRI machine. So this is difficult. And the reason for this is, I think, it's economical, I think. Because what happens is, for example, in Kenya, the GDP, out of the GDP, only 5% of the GDP is allocated to health. So it is by the government for government facilities. And this is used to pay salaries. It is used to maybe maintain hospitals. It is used to pay for programs. So very little trickles down to neurosurgery. Another problem we have is none of the equipment is manufactured locally or assembled locally. Everything has to be imported. Everything from beds to theater lights to anesthetic machines to, any medical equipment has to be imported. And this is a challenge for us. One is because apart from buying things for example, in dollars or in euros, which is already expensive. For example, in Kenya, one 1 euro is probably 170 shillings. So you see, it's quite expensive. And then on each item you buy, you have to pay fairly high taxes, almost 50% import duty, and then there are many levies and licenses. So it's very difficult to import anything. It becomes even more expensive to buy any equipment here than it is to buy it in North America or Europe, where equipment is already assembled locally. People have tried to buy used equipment in good shape, or even get donations from abroad, but still there are challenges. For example, you can buy a machine that is no longer in production, and when it breaks down, then it becomes very difficult to service it because you cannot buy the spare parts. And so a lot of these machines, they work for some time, and they're they are relegated to the stores, and they end up gathering dust, and we're back to where we had no machine in the first place. Even so, I mean, people do try. This slide just shows you some local innovation. I hope it's clear. But on the right side, you can see a commercially made patty. And here on the left in the middle, and on the left side, you can see patties that are made locally. So all it is a piece of, maybe a piece of gauze or a piece of cotton that is sterilized and tied to a string, and works just as well as the commercially made patty. So these are things that some facilities do to enable them to continue operating. Here is an example of something that has been manufactured in Africa. This is it's a stereotactic frame. It's a stereotactic device that has been manufactured in South Africa by actually African neurosurgeons, and it's called the Cape Town stereotactic frame. It's been there for a long time. It's you can see it's a steel box that has X, Y, and Z axis, and then you have like a frame in the center where you can and a movable. Of course, all these axes are movable. So basically, you can use this to plan your stereotaxis, and it's much cheaper than, for example, a Excel frame or having a neural navigation system. And it's run by very, very cheap software. It has been around for a long time, over 20 years, and the software that you need to input into the CT scan machine or into the MRI machine is just from a flash disk. So it's an innovation that we have used to achieve maybe stereotactic biopsies, and in some places even treat deep brain stimulation. That said, we do have a lot of support. In spite of our efforts, we get a lot of support from neurosurgeons, our brothers outside of Africa. And you'll find that in many, many centers that have the capacity, surgical camps are organized. For example, Professor Ortel comes to my hospital for the last 4 years, once a year in February, and spends about a week. He comes with a team of other surgeons and anesthetists, and sometimes nurses. And for that 1 week, we have 2 theaters running and do as many cases as we can, and this helps a lot in terms of course, patients benefit from experience of our colleagues outside the country. They sometimes benefit from some materials that we don't have, like good flow seal, good hemostats, etc. And as much as it benefits in that period, it's really not sustainable, because once the team leaves, and we have to continue struggling, and we have to wait for another year. But we do appreciate the support. There are more sustained, I would say, collaborations. For example, in Zanzibar, NAD Foundation has set up a hospital and center, and throughout the year they have visiting volunteers. So you have a visiting neurosurgeon, or maybe 2 or 3 with nurses and anesthetists coming throughout the year and training. And it has happened also at Duke University and Mulago Hospital, and also WFNS Center in Morocco. For example, Kaltstotz and Medtronic really sponsor a lot of continuous medical education and workshops and really educate a lot of sub-Saharan African neurosurgeons to bridge the gap in knowledge. And of course, we have foreign universities, US-based universities, European universities offering grants and research opportunities and training in research. So this is ongoing. And of course, we have observerships and short fellowships for neurosurgeons. These are very much available. I'll just talk about my situation, maybe give a few cases as I wind up. So this is my hospital here. It's Coast General Teaching and Referral Hospital. The entry is just next to the road. And the map shows the coastal region of Kenya. And Mombasa is this little town here. And this hospital serves as a catchment area for all these counties. So all these patients end up here with their various conditions. This is an example of a child with a frontonasal encephalitis. This is what we see commonly. I'll just give a few examples. It's not exhaustive, but this is a child with a frontonasal encephalocele who was operated here. And a few months later, the same child with quite a good effect. This is a patient we have in our countries, in sub-Saharan African countries. We have something unique. We have a lot of motorcycle riders who buy cheap motorcycles to employ themselves, and they provide transport. They carry people around for a small fee, and that's how they make their living. The problem is they don't wear helmets. They don't protect themselves. And so we have a lot of this young male patients having severe injuries. So this is a patient with a severe head injury from a boda accident. We see this quite often. We see it every day. Fortunately for him, he recovered quite well. You can see he had extensive injury. He had, I think, a compound fracture of this area with a lot of skin loss and tissue loss, and this required quite a lot of work and reconstruction to make him, but he is well today. This is something also that is unique. Well, I would not say unique, but we see quite often. This is a patient, a 31-year-old male with L3, L4, tubercular spondylodiscitis, who presented with lower limb weakness and bladder dysfunction. Anti-TB drugs do not help, and so this is a kind of patient who we decided to decompress and fuse, and that was what we did, and we had a good result. He has recovered full motor function after some months. Another case of spondylodiscitis, this time thoracic spine. This patient was quite obese and would barely move his limbs, and this is what we did. We did anterior debridement with a paramesh cage. This is a cheap and very easily acquired implants. So you can see the paramesh cage placed in there, and we did posterior screws and rods. And this is the same patient now, very happy. He was able to walk after a few weeks. Sorry, this image is not clear, but again, this is another example of what we see here. This is a thoracic intramedullary lesion. It turned out to be bilharzia, schistosomiasis. This is something I think quite unusual. So I think those are my cases. I will maybe give time for questions or anything from here. Thank you.
Perfect. Thank you very much for your presentation. If there are any questions, please feel free to turn on your microphone and participate. Unfortunately, since we don't have we have a free version of Zoom, we only have 5.5 minutes left on the presentation. But if there are any other questions, we can continue with the second Zoom presentation with the second link that you received. Would anybody want to start with some questions? If not, I
have a question.
Yes, please.
Yeah, doctor. First of all, thank you for your presentation. Really good, very well presented. I have a question. The last case, you have said it was schistosomiasis.
Yes, the histology showed that it was schistosomiasis, yes.
Oh, how was it treated? What was the process?
So the patient presented with basically a lower limb weakness, progressive, and bladder dysfunction. And after radiology, we found, I'm sorry, my images are not too clear, but we found intradural, intramedullary tumor, and the pathologist would say probably misled us because he thought of ependymoma or astrocytoma. So we did not start drugs immediately. We actually ended up doing a laminectomy and removal of the lesion, and only then did we discover that it was schistosomiasis, after which he was put on chemotherapy.
Okay, thank you.
Thank you.
I had a question about the programs that are put in place to retain people, because you said so it's not legally enforced that neurosurgeons or doctors generally stay in the region or stay in the country, but you said that it's very much encouraged. How do you achieve that?
Okay. What happens is the hospital or the county administrations will pay for training. So they will select a few candidates and pay for their training locally. And as the candidate is going, he has to sign that he will be bonded for at least 4 years to the training hospital, so that when he finishes his training or she finishes the training, the candidate will come back and work in that institution for at least 4 years. So that ensures that there is service delivered for 4 years. If the candidate absconds and leaves the country, there's no way that the authorities can catch him. But if they want to leave their work voluntarily, then they have to pay back the bond. So that ensures that the neurosurgeons stay within those training institutions. Sorry, I can't hear you very well.
Oh, I'm sorry. I was saying that we have similar programs like this in Germany or also in France to keep, well, not necessarily for all the specialties, but to at least keep general physicians in the regions where there are the least physicians. So, and that works very well. I know in Germany, well, it's in progress, but it's working very well right now. So that it's also a very good opportunity also in Kenya then to keep the neurosurgeons and specialists that you need.
Yes. All right, thank you.
Are there any other questions? We still have 1.5 minutes before the Zoom session closes. Then I had one last question if nobody has any other questions. How much time can you afford for research? You or different or residents or new young doctors, how much time can be afforded for research? Or is that not at all a priority?
Okay. A lot of the hospitals in the probably the university teaching hospitals, and research is a priority. But in a hospital like mine, which is a referral hospital, it is encouraged, but it's not a priority. It is normally service based. So I think it just depends on the individual's interest, and whether they want to put out research or not. I think, for example, where I'm from, I think there's a lot of pathology and a lot of data that I think goes wasted. I think that even though there is no dedicated time for research, it is possible to do research within our institutions.
Okay. Interesting. Well, thank you very much. Everybody now that is part of the committee If you can then just click on the second link that you received, I'll start the new session. See you all in just in